Hello, I'm Dr. Randall Sechrest, your host for eOrthopodTV. Today we'll be talking remotely once again with Dr. Wiliam Seeds. Dr. Seeds is an orthopedic surgeon who practices in Ashtabula, Ohio. Dr. Seeds is also the sports medicine provider for the Great Center in Geneva, Ohio. Thanks for joining us again today, Dr. Seeds.
Thanks for having me, Randy. A pleasure to be here.
Well, Dr. Seeds, what I thought we would talk about today is another common type of bursitis that you and I probably see a lot of, especially in folks who spend a lot of time on their knees. And that's prepatellar bursitis. And that usually is a disease that starts because people spend a lot of time on their knees and irritate the front portion of their knees just under the kneecap. And that's what you and I would call prepatellar bursitis. So if you could, give us a little insight in why this occurs where it does and what the process that's going on in that condition is.
Well, usually, Randy, the patients that present to me with this problem are people that have had a kind of a repetitive type of trauma directly on the anterior part of their knee. Either they may be typical type of labor, maybe laying carpets or working on the ground with tile or specific things like that, where there's just repetitive trauma to the top of over the kneecap itself and below, where they get a kind of a constant irritation, swelling, and it doesn't go away. It's something that they follow, and it stays there. And at first it isn't painful. They get some swelling, but then they get into those stages where it does become painful, very painful to the touch. That's usually what brings them to see me. It isn't the swelling, it's when it starts to become painful.
And you mentioned carpet layers and labor type folks who spend a lot of time on their knees. Do you see this in any other folks typically?
Yeah, I'll see this in acute injuries, in sports injuries. I will see it in soccer, football, baseball, tennis, volleyball players. I mean, we see a single incident where there's trauma to the knee and they get a little swelling, and it's been sometimes even the trainers will see these people and they think it's a little more of a bigger problem, and we end up seeing them and it's just really it's a patellar bursitis where they've just inflamed the bursa, and these people respond very, very quickly to some initial therapy or anti-inflammatories and can do very well with it.
You know, I think we commonly toss around these words like bursa and bursitis. Can you give the viewer some idea of what this structure really is that we call the bursa, and what's going on when we diagnose bursitis? What sort of problem does bursitis really mean?
Right. Typically, Randy, what I try to explain to patients is the bursa is a lubricating type of layer that covers part of the kneecap and the patellar tendon to help the tendon function better in its normal activity. And I tell them that usually imagine it as being paper thin. And what happens is it gets irritated and becomes inflamed, and then it becomes sometimes boggy, like thicker in consistency, and sometimes it swells up like a balloon. And depending on the variation in how that bursa reacts, it can be painful, and it can restrict motion in the knee, and those type of things.
When you see this patient for the first time in your office, what are you going to be concerned about?
Well, typically when we see people with bursal problems, number one is usually because it is a type of, it usually comes from some direct injury or trauma to the knee or repetitive rubbing. We're always having in the back of our mind, we're concerned about any type of infectious process that can be involved with this also, where you'll have an infected bursa as opposed to an inflamed or non-infected type of bursa. And that's always important to pick up early. Because of that direct trauma, sometimes there can be an initial breakthrough of the skin or something that can get into that bursal area and infect it. So it's real important to make sure that we can realize that difference initially, and then and then take the exam further and where we go with treatment.
You know, it's interesting. I think that anytime someone sees a swelling in front of their knee, they typically become concerned. I mean, they think of all sorts of bad things that this could be, and most of these, as you and I know, are pretty much benign. How do you address a patient that's come in with this condition? Do you treat them conservatively? Is this something that you're going to recommend X-rays, recommend more tests? How do you evaluate these patients?
Well, that's what you said is correct, Randy. A lot of the patients will come in and tell me initially that they've been told they have water on the knee. You know, that specific comment of that I've got water on my knee, doc, and what are we going to do about it? And usually, when I hear water on the knee, I'm thinking more of I'm thinking of fluid inside the knee, a knee effusion where there's something interarticular in the joint. Whereas opposed to this is more of a swelling, as you've said, that's outside of the joint space, and it absolutely changes the approach and how you're looking at this. So usually with all these patients, we'll get an X-ray. I want to make sure that we can identify that there is no foreign body or something that may be associated with the initiation of this inflammation. You want to rule out any stress fracture or fracture of the patella or things like that sometimes you can pick up. So we'll do our due diligence in doing the X-ray to look at the bony anatomy and see if we can also look at any soft tissue changes that we can see on the X-ray. And then from there, it's the exam. And the exam is important in how the patient presents. Has it been there for a long period of time? Is this a very significant problem as far as to palpation or to exam? Is it very tender? Is it restricting motion? How much fluid do I believe is there? Or is it just a very small, what I call like a bogginess of where it's a thickened almost bursa and not really fluid filled? And based on that, then I can make the recommendations of where maybe we can initially start off conservatively with an anti-inflammatory to see if we can cool down the bursitis, versus sometimes I'm aggressive with these in aspirating the fluid off of the bursa and then injecting a steroid in there to sclerose that bursa to stop it from building up fluid again. And number one, number two, to treat the pain by removing the fluid and to get them active again.
I think you did raise an important point, and that is that the bursa does not communicate with the knee joint. I think that's sometimes confusing for patients. And like you say, they come in and say, I've got water on the knee, and they assume something's wrong on the inside of their knee joint. But as you and I know, that bursa does not communicate with the knee. That's a separate anatomical area, a separate anatomical cavity at the knee joint versus the bursa. So I think that's a very important point for patients to understand. And when they're seeing this swelling on the front of the knee, it's unlikely to include swelling in the joint. Swelling in the joint shows up in totally different places, usually on the top of the knee or above the kneecap. Sometimes you can, as the knee just balloons up, you see it all around, but it's sometimes with small amounts of fluid in the knee joint very difficult to see any sort of swelling unless you're really used to looking at this and understand what you're looking at. So anyway, I think that's a very important point to get across to patients, that this is not necessarily a knee joint problem. This is a problem that happens outside the knee joint, usually in front of the kneecap, in front of the joint capsule, in front of the patellar tendon, in front of all those structures in the knee. And it's usually not good news if it communicates. One of the things that I think we worry about is as you said, the infection. And if this area gets infected, what you and I are worried about is not only the infection in the bursa, but the possibility that infection can spread into the knee joint, which is a far more serious problem than just an infection in a bursa in front of the knee joint. So thanks for bringing that out for patients. Now, you'd mentioned that you inject these with corticosteroids. Is that a pretty typical treatment regimen for you? Are you going to inject most of these?
Yeah, I'm pretty aggressive with again, with this Bursa concept. with trying to resolve that fluid problem and the sensitivity problem, because I don't want it becoming a chronic problem. And anytime you have fluid that sits in an area for a specific period of time, it can sometimes set itself as a nidus, as we call it, for an infection. It can be a locculation of fluid that down the road, if there does become some type of a communication to that area, if they're still doing their work or their sport and they get a nick in that area, they're more likely, unfortunately, then to go on to that next stage. So I'm trying to think ahead and trying to resolve this problem the fastest that I can for them, and what I believe is potentially saving them from bigger problems down the road.
Yeah, I think that since most of these patients that come into our office with this condition are really folks who spend a lot of time on their knees. You had mentioned that yes, we do see it acutely with people who have had one traumatic event, but a lot of these folks have been doing work on their knees for years. So I think we probably ought to talk a bit about prevention and the importance of, perhaps if you're spending a lot of time on your knees, like a carpet layer or a plumber or even a carpenter, that you probably ought to seriously consider using knee pads or something when you get on the floor to prevent this disease. Do you have that discussion with patients?
Yes, absolutely, Randy. The protection is just as important as the treatment, and understanding that it can be that what they're doing to protect not only the Bursa, from what I believe they're going to help themselves, but also the knee itself, the mechanics of the patellofemoral joint, where I believe that any type of cushion that you can give the knee when you're on your knees for a period of time, you're going to help all those structures. So I think it's very important to understand that kind of maintenance over time makes a significant difference, because every time you do that, it definitely will build up as a problem over time. The tissue just won't respond over time to that type of conditioning, and you want to be able to protect it the best you can.
Do you have any recommendations in terms of types of pads? I've seen some people that just use a regular foam pad similar to what you would see in a football player or a volleyball player. But at the hardware stores, sometimes you can see these very sophisticated knee pads that actually try to distribute the weight. They're more hard rubber, they're not just foam, and they really try to distribute the forces across the front of the knee so that you don't just get that pressure build up right at the inferior pole or the bottom of the patella. Do you make any recommendations yourself in terms of where patients should go to obtain a pad?
It depends on the condition and the works. If it's a repetitive type of traumatic thing, or is it sports related where it's one time. For the workers that are on their knees, I will recommend that they try a couple of different products before and find something that feels not only that's going to give them the support, but also gives them the stability. And I try to find what you brought up, the more rigid type style of a knee protector, as opposed to my sport type of athletes. I'll do more of a padded, foam type padded or neoprene padded type of product versus the rigid for the repetitive trauma.
Now, in your athletes, do you restrict them in any way once they've had one of these injuries, and maybe it's a fairly fresh injury, several weeks old? Are you going to restrict them from their sport, or do you feel like that most of them can make a few adjustments, get a pad, and go back to playing?
Yeah, most of them are very responsive to the treatment, and most of them get back pretty quickly. And I think the important thing is to keep an eye on it. I do recommend icing then after activities for a period of time, usually about the next month to 6 weeks after the initiating event. If we've treated it, I think ice helps a lot post-injury. And I'll also sometimes, depending on the degree of injury and if we aspirated or did things like that, if they're still in the sport, I'll even have them do a compressive type of wrap around the knee afterwards with the ice. So that's usually how I follow it, and we do really well, I believe, in getting to those people pretty early.
Well, let's talk a little bit about when this fails, and I think this is probably going to be more likely to fail in the patient who has a chronic bursitis that's been there a long time. It's very thick. The bursa itself is very thick, and these have a tendency just to continue to get thicker and thicker. Not only do these patients tend to form a thick callus on the front of their knee, but that bursal tissue becomes thicker and thicker as well. What makes you consider surgery in these patients? When do you stop conservative care and suggest to the patient that they may be better served with an operation?
Well, that's usually I'm a little bit of if I've tried to aspirate it a couple of times and inject it and it comes back pretty quickly, or the fact that they didn't respond to it at all is usually the trigger of where I'll discuss it with them. And what's most important, I think, in this is understanding what that patient's work is and knowing and letting them know ahead of time that if I'm going to take this out, the surgery itself is going to restrict them from being on their knees for potentially a couple of months, because you're going in there and removing that bursa, and when you remove it, as much as the surgery isn't that invasive, you're still removing a bursa that has a pretty decent blood supply. So the problem you have after the surgery is you're going to have a little bit of a loculation of blood under the skin, and it takes a little while to resorb that, and you certainly don't want trauma to that area while that tissue is healing. So I tend to make sure that my patients really understand that if we're going to do this surgery to correct this problem, we're going to have some issues with swelling and so forth where the knee can't tolerate that type of trauma from work. So that's always an important thing to discuss with these patients, where sometimes they can't afford to take that time, and you've got to make sure you understand what you're getting into with that surgery.
Well, how long do you think it takes for someone to get over the surgery and get back to doing their job? For example, a plumber or a carpet layer. Are we talking weeks? Are we talking months? How long?
Well, I think for most of them, we can get them back to work in their environment within a couple of weeks, 2 to 4 weeks. But as far as getting on their knee, they have to be smarter in protecting their knee, and I don't let them do any direct getting direct pressure to that knee, even protected. I try to keep them off of that for at least up to 2 months because of the problems, as I said, with the swelling and so forth post-operatively and the incision, because they are still very sensitive afterwards. And I think a safe time frame in discussing all these patients where they can go back repetitively pushing that knee with a pad is probably a 3-month time frame, is a good standard estimate to make sure they understand that.
Well, and a couple of details about the surgery itself. Is this an outpatient surgery, or do you keep these patients in the hospital overnight?
No, I will this is an outpatient surgery, and it's somebody that we'll get them home immediately, and we'll see them the next day, because we do want to look at the wound, and we do want to get them started with motion around the knee and have them doing some of their own exercises. But for the most part, it's unless it's an infectious type of process where we may choose to keep them in the hospital for some antibiotics or something for a day or so, or we may put a drain in for those patients. This is something that's an outpatient process, and they go home that same day.
And what about crutches? Do you allow them to weight bear? Do you put them on crutches? And if you do, for how long?
What I will usually do is I'll usually brace them. I'll put them in a brace, so I don't want them bending their knee the first 24, 48 hours because I don't want any stress on the incision, and I'm trying to keep that swelling down to a minimum and remind the patient that they have had an operation, because I think most of them feel pretty good, and they try to test it pretty early. So I will have them have crutches. I'll have them do partial weight bearing with a brace, and then I'll have them see the therapist, who will slowly work them out of that brace and the crutches to to get them to where, they're not hurting themselves and we're comfortable with their progression.
Well, let's talk a little bit about the potential complications of this operation. What are you worried about both during the operation and then in the postoperative period as the patient recovers?
I think my biggest problem or the biggest thing that I worry about is the wound breakdown from the patients doing too much too soon, where they get a little swelling, a little bleeding postoperatively inside that site, and they're feeling good and they're trying to do too much with that knee and they break open the incision a little bit, or there's a little what we call wound dehiscence, where the sutures underneath the skin open up a little bit and they get a little leakage of that fluid or blood. The other is obviously some bleeding underneath the incision in that wound where I feel that they might have too much, and that's where I'll aspirate that early on. I'll take that off, then with a small needle I'll remove that if I can. So those are the two things that I initially look out for, and then always with any surgical procedure like that is infection. We look for postoperative changes that could lead to infection.
And as they recover down the road, any other complications that you tend to warn the patient about?
I do warn them that there's the possibility that they could have a recurrence of that the bursa can form to some degree again with some of the tissue that is still there, that there is some residual tissue that may, with the same repetitive trauma, they can get a recurrence, and that's usually the one thing that I will, people got to make sure that they understand that that's always a possibility that they can have that happen even if they've had the bursa removed.
Well, I think this has been a wonderful discussion about prepatellar bursitis, and I think that as we close this discussion, is there anything that you feel like we haven't discussed that patients need to know about this condition?
I think we touched on it right there at the beginning, Randy. The biggest thing the point I try to make with the patients initially is, number one, is to try to make them understand that this is not a process that's inside the knee, it's outside the knee, and the management is going to be different. And just to relieve them that structurally this is something that is not as bad as they may have anticipated or been told, and that's always an important thing to communicate with the patient. And the other is to get an idea of how this was created or how this was initiated, and getting an idea of what type of work that patient does, because you need to really understand that, I think, in making good judgments of how to treat that, and to keep the patient involved in making those decisions with you in treatment. And then I think you've got a good way of taking care of this.
Yeah, I think the only thing that I would add to that is that this is one of those disease processes that really comes from what you're doing. I mean, in most cases, this is a repetitive injury from being on your knees, and you can really reduce your chances of developing symptomatic prepatellar bursitis by doing some simple things. And just, if you spend a lot of time on your knees, invest in a good set of knee pads and use them. They're not going to help you if you don't have them on. So you need to take the time to use them. And if this is part of your job, I would probably suggest to patients that do the good thing for yourself and invest in a good set of knee pads and put them on.
Absolutely agree with that, Randy.
Well, thanks so much for joining us today and explaining prepatellar bursitis. Look forward to further discussions in the future.
You too, Randy. You have a good day. Thank you.